Dr. Kamenets came looking for you. Yeah. I will call him. I will call.
Yes, I can. Okay, good afternoon, dear colleagues. I need to continue. And first of all, I would like to introduce our panel, our friends and colleagues. Professor Henrich from the Switzerland, Professor Novitsky from Lviv, and Professor Sergeyenko from Kiev. Waiting for him, okay. And first presentation, Professor Novitsky, idiopathic epiretinal membranes, indications for removal and results. Please.
Dear colleagues, dear friends, it's very good experience to conduct our session in English language. It is not easy, but I will try to do it. So, about idiopathic epiretinal membranes, indications for removal and results. Professor Ivanov, a professor of Kyiv Medical University, was the first one who in 1865 described epiretinal membrane as the proliferation of cellular tissue on the surface of the retina. Other terms of epiretinal membrane are macular pucker, cellophane macular opacity, and preretinal macular fibrosis. The vast majority of epiretinal membranes cases are considered as idiopathic. Its prevalence increases with age. There are two hypotheses for its pathophysiology. One is that posterior vitreous detachment causing a cleft in the internal limiting membrane, which leads to glial cell migration. The other one is that vitreous liquefaction, which induced vitreoskisis, and a remnant of vitreous collagen is a scaffold for epiretinal membrane formation. Most often, patients with epiretinal membranes are asymptomatic, but in some patients, epiretinal membrane progresses and cause metamorphopsia, micropsia, macropsia, and decrease of visual acuity. Especially metamorphopsia interferes with the decreasing of the quality of life. Ophthalmoscopy is the best tool for diagnosis of epiretinal membranes, and it shows that we can see irregular reflex in the macular region and retinal folds as a result of epiretinal membrane traction. OCT is the most useful tool for epiretinal membrane diagnosis, and we use not only MIRS, majority acceptable classification of stages of epiretinal membrane by Govetto, proposed in 2017. First stage shows shows that there is epiretinal membrane was present of foveal P. The second stage, of course, epiretinal membrane, more thick, and absence of foveal P. Stage 3, absence of foveal pit, presence of ectopic inner foveal layers, and stage 4 shows ectopic of inner foveal layers and disruptors of these layers. The Blue Mountain study showed that only 20% of epiretinal membranes progressed over 5 years, 26% regressed, and 39% remained unchanged. That is very essential for understanding for indications for operation. Traditionally, indications for surgery has been based on the severity of symptoms rather than OCT appearance. We know very good that sometimes we can see very severe OCT membrane on OCT, but visual acuity is good and the patient doesn't complain for metamorphopsia. But from another hand, we also know that visual outcomes after surgery are related to preoperative visual acuity and status. But no objective criteria for indication surgical removal of epiretinal membrane have been established just for now. Furthermore, there is not consensus of whether to undertake internal limiting membrane removal during surgery. We know that advantages of internal limiting membrane peeling include complete removal of epiretinal membrane and prevention of recurrence of epiretinal membrane. So, purpose of our study was to investigate the outcomes of epiretinal membrane removal in asymptomatic cases compared with those with metamorphopsia. There were two groups in our investigations. In first group, patients complained for metamorphopsia. There were 24 patients, 28 eyes, 28 patients. And in second group, there were 24 patients with no complaints. Of course, stages is stages 2 and 3 and 4 in first group were much more than in second group. For all patients, there were done 25 gauge pars plana vitrectomy with epiretinal membrane removal and internal limiting membrane peeling. The efficacy criteria of epiretinal membrane removal were improvement in visual acuity, resolution of metamorphopsia, and change in central retinal thickness. That is short movie how we remove epiretinal membrane. Of course, not of course, but generally we stain epiretinal membrane with some dye, dual blue, so on. It is easy to hold epiretinal membrane and remove it. In all cases, we try to remove the epiretinal membrane in the direction of the central part of the macula, and the purpose not to destroy it overall. So epiretinal membrane is removed, and after that we remove. Probably this video is not running, but okay, it's a classic internal limiting membrane peeling. What are results of our investigations? In both groups, we had increasing in visual acuity thanks by fake emulsification, first of all. Of course, we had decrease of central retinal thickness. But what is very important, that metamorphopsia in first group disappeared only in 3 cases, decreased in 6 cases, and remained unchanged in 19 cases. That is some examples of good results, but sometimes we are not such successful, and central thickness of the retina remain the same. We removed epiretinal membrane, but central thickness is very, very big. Very important is post-operative treatment. We know that, unfortunately, after surgery, epiretinal membrane, after removal of epiretinal membrane, persistent or new onset macular edema frequently occurs. There is not standard therapeutic strategy for this situation. We used, for example, triamcinolone intravitreal, intraocular injections and subtenons, and sometimes it helps. So, as conclusion, in most cases of metamorphopsia, these complaints did not disappear after epiretinal membrane removal, and although the anatomical changes of the retina improved, visual acuity increased only slightly. Therefore, it is possible to recommend removal of epiretinal membranes starting from the second stage of the disease before the appearance of complaints of metamorphopsia. I'd like to invite you to have a fifth Vitreoretinal Symposium, Retinal View 2025, which will be held in July, 4th of July this year in Lviv. Thank you very much for your attention.
Thank you very much, Igor Yaroslavovich, for nice presentation and your experience in the field of epiretinal membrane and epimacular membrane. So maybe any questions from the panel? Yeah, Professor Sergeyenko.
Igor Yaroslavovich, do you do complete vitrectomy in your cases or only core vitrectomy? And the first questions, and the second, how often you use staining twice or 3rd times during operation, because sometimes membranes separate for several layers.
I always perform complete vitrectomy. I'm trying to complete all complete vitrectomy as much as it is. And sometimes, you're right, we use second dyeing for complete removal of epiretinal membrane. Sometimes it's we can see that epiretinal membrane are multi-layers. Yes, you're right.
Thank you. Very short question from Professor Henrich.
You mentioned macular edema as a possible consequence, as a side effect, if you will, as a complication of the intervention. Have you identified any risk factors for the formation of postoperative macular edema?
I don't know which risk factors can be discuss with patients before operation. I don't know. Maybe you can tell something about this.
I find it very difficult. The only risk factor that I personally know of is microcystic edema preoperatively. Microcystic edema many times is persistent, and you can operate or not operate, and it doesn't change much in most cases. But for the rest, I think it's very difficult to predict macular edema, and sometimes it can be frustrating if you have asymptomatic patients and you operate, and then you have a macular edema afterwards. That was where my question came from. How do we know that we help the patient if we don't know if there's a macular edema maybe after surgery? I find it difficult.
What what do you advise to do in such cases? Do you discuss these questions with patients?
Yes, absolutely. Those of you who have known the Swiss system, we spend more time talking to the patient than operating the patient for the most part. And so, yes, we go over really almost all relevant complications before the surgery. Almost too much. I think it's important, but sometimes it's almost too much. And then we decide together. And I think that's probably the way you do it as well.
I totally agree that we have make the patients of a partner of decision. It's very important to avoid any problems after surgery with patients.
Thank you very much. Thank you, Igor Yaroslavovic. Need to be a little bit faster. And don't forget about duration of your presentation. So the next speaker is Dikunova Darina from Kyiv, experience in using Red PRGF gel for macular hole surgery, 2 years review.
Good day, dear colleagues. I want to share with you today my experience in using NDRF gel technology for closing the macular holes. I have no financial disclosures. It's not a secret for us that macular hole, especially complicated one like myopia associated or sometimes diabetic associated, could be challenging and could be refractive, and the rates of closing would be lower than the idiopathic macular hole of a small size. That is why a lot of adjuvants are provided and used by vitreoretinal surgeons all over the world. And it's nothing really brand new about the platelet concentrates. It was used first time back to 1996, and the surgery went successfully. But the lack of standardization, terminology, and standardization of understanding where we should use it, in what form it will be better, what form is more suitable for different types of macular holes. So that is why in 2023 in Griffiths Archives, the big article was published by Francesco Gilamini and co-authors describing the utilization of platelet concentrates in different forms and the surgical techniques and everything. Principally, the platelet derivatives are divided into 3 groups. It's liquid form or PRP, PRP activated gel, which one we actually prefer to use in our practice, and PRF. And recently, a pretty new technology of BTI and RED of creating PRGF gel are provided, and it promised to have higher regenerative activity. So BTI technology gives its special centrifuge for preparing the liquid or gel activated form of PRGF, and also special camera which helps to create a membrane of PRGF membrane form. And the recent studies, like in 2020, 2022, were published already with using not PRP, but PRGF gel, PRGF, in the combination with the ILM peeling. So, what the the most valuable principle of PRGF and why we choose it is that the technology of preparation helps us to achieve higher concentration of the growth factors, lower concentration of white blood cells. That is how we provide high regenerative activity and lower inflammatory response. And also, this technology is pretty well standardized, so it's pretty easy to teach nurses and the staff and to prepare it properly in the proper time, and everything is going like like a orchestra music. So it's pretty easy to provide it in practice because we kind of have some time for activation within which we need to put it inside the macular hole. So again, basically there is two principal form: injectable PRGF or liquid PRGF, including it also is really used often in eye drop serum and etc. And the membrane form, prepared in special camera. During these 2 years, 27 patients were analyzed, and the majority of them were presented with the macular hole stage 3 and macular hole stage 4, and some of them were presented with the really interesting atypical diabetic macular hole, which is shown on the left. And most of them were large size, a little less extra large, and in one and also some amount, like about 30%, medium-sized hole. And in one case, we have a macular hole which had a monocular patient. It had small size, but what was gives pretty much disturbance to a patient since the patient, she was monocular. What I personally consider about the use of this technique, that it seems to provide the higher quality of reorganization of macular surface, with the pretty well reorganization of inner and outer foveal integrity. Mostly, technology of plasma derivatives, and especially PRGF, are now described for treating refractive macular holes as all the adjuvants. So that's where we started. So we had macular hole which didn't close with the typical ILM peeling and C3FA tamponade. That is why we proceed to another vitrectomy, putting PRGF gel and again C3FA tamponade, and we see macular hole pretty well closed. On the next case, we see, I guess, pretty dramatic diabetes-associated macular hole. Interesting thing that this patient with the diabetes type 1, she has really tiny, small little spots of fractional detachment, but pretty severe macular hole with the huge elevation of the margins and significant vision loss. So we decided to do the next surgical strategy for her. We do ILM peeling, ILM inverted flap forming, and then cover it with a PRGF gel. There are also recent articles published with offering the PRGF gel as an adjuvant for different plugs sticking to the retina. So here we see, inverted flap, and then fluid air exchange, and we will cover it with the activated plasma, activated PRGF gel. Even though light massage of the retina, even though plasma quality, as we see for this patient, wasn't pretty good since she has diabetic not really well controlled. And then in about 2 months, we observed this patient with the closing of macular hole, but still pretty noticeable amount of subretinal fluid left, which slightly progrediently resorbed during this year of observation. And for this type of macular hole, I think macular reorganization is looking. And her visual acuity increased dramatically, like X10. Patient is very happy. Recent years, some works are published about the PRGF gel in no retina touch technique. So it kind of can let us, in some cases, avoid ILM peeling. Most of these articles are published for closing the lamellar macular hole, but we decided that we could also use it for this monocular patient, since we see a hole without severe elevation of the margins. It's pretty small sized. And I think in these cases, at first we consider whether we should operate this patient at all. But since she, again, was monocular, she already had a cataract grade 2, so, and has some vision loss, and was pretty active lady. So she wanted to have good vision, good quality of vision, see, and do everyday activity. That's why we decided that combining the phacosurgery and the core vitrectomy with placing PRGF gel would help us to help the patient and stay in the less or more safe zone without avoiding any retina touching or any retina traumatizing. So first question came to your mind after whether we could avoid ILM peeling. Could PRGF gel replace it? But recent research hasn't shown significant difference of closure rates in ILM peeling solo or ILM peeling flap forming and ILM peeling plus PRGF gel plaque covering. So again, the closure rates are pretty the same, but the quality of the closure could differ. And in the particular cases like lamellar macular hole, if you need to proceed to operation, or macular hole like I just showed before, could be considered of performing the surgery with the gel and to avoid ILM peeling in some cases. We also tried to use PRGF gel plug assist in a combination with the silicone oil, which also worked pretty well, except in 2 months of observation, we saw the slightly ARM formation. Yeah, I'm sorry. But after we removed silicone oil, removed the ERM, and again saw the macular hole pretty well close. To sum it up, I can say that PRGF gel therapy is effective and safe adjuvant therapy in treating complicated macular holes, can be safe and effective for primary macular holes as the alternative for ILM flap techniques, for ILM peeling techniques, and can be considered to use in addition to another alternative treatment to fixate the graft. Thank you.
Thank you very much, Darina. Very interesting presentation. Unfortunately, we don't have any time for discussion. If we have a time after session, we discuss very interesting question about your topic. So the next speaker... sorry. Я перейду на українську мову.
I would like to use the opportunity to thank our friend
to present very scientific presentation here, and waiting for you the next year, and see you in October in OFTA Cafe in the Switzerland. Yeah, thank you very much, Professor Bernardo.
Thank you very much. Congratulations to this fantastic meeting once again, and hope to see as many as possible of you in Lugano in October.
Have a safe trip, please. Bye. And the next speaker, Professor Marin Stopa, with a very interesting topic about macular hole closure without the endotamponade, please.
I would like to thank for the invitation to 2025 edition of Filatov Memorial Lectures. And today I'm gonna talk on how to close macular holes without using any endotamponade. In 1991, Kelly and Wendell introduced macular hole surgery, and intraocular tamponade, usually gas, was integral part of this kind of operation. Since 1991, since its introduction, there has been a lot of variations of macular hole surgery. In 1997, Eckert introduced ILM peeling. In 2009, Michaleska introduced ILM flap. There are different techniques, sometimes using gas, sometimes silicone oil, but they all used intraocular tamponade. Success rate varies between 90 and 100% currently. However, do we really need a tamponade? Do we really need gas at all? And the other question is, would it be beneficial to eliminate gas? And there are certain drawbacks associated with the use of gas endotamponade. Patients cannot see after the surgery because of the gas. Also, air travel is not possible because when you get on the plane, then the gas bubble expands. Usually some form of positioning is necessary. If it's not strict positioning, patients need to maintain certain form of positioning. And finally, it's difficult to perform OCTs through gas. There are also certain complications related to gas. There is possibility of intraocular pressure elevation. Gas contributes to cataract formation, and also there have been reports on possible visual field defects related to the presence of gas inside the eye. Next question is, do you really know how gas works in macular hole surgery? Is it the buoyant force of the gas bubble on the macular hole? Is it the effect of surface tension? Or is it the bridging effect of the gas? Or is gas blocking the ingress of intraocular fluid into the hole that contributes to macular hole closure? Actually, you really don't know what is responsible for macular hole closure. Given all these controversies regarding gas and complications related to intraocular gas usage, we developed a simple alternative vitreoretinal technique that allows for macular hole closure without filling the vitreous cavity with gas, and then later it allows to do OCTs right after the surgery. Early air travel is achievable, and there is no need for positioning of the patient. We performed a study where we included idiopathic macular holes, and we used International Vitreomacular Traction Study group classification of the macular holes into small, medium, and large holes. And we performed 25 or 27 gauge vitrectomy without any tamponade. Preoperative and postoperative visual acuity of the and the foveal structure on OCT were evaluated. The surgical technique is based on the formation of a viscoelastic assisted temporal internal limiting membrane flap without any gas tamponade. After you prepare the flap under perfluorocarbon liquid, you put cohesive viscoelastic on top of the ILM to keep it in place, and then you remove decaling and you don't fill the eye with gas. Here you can see intraoperative videos of the surgery. This is the same patient but different stages of the surgery. In the upper left you can see the staining and PFCL introduction onto the macular area, and the right lower part of the video shows creation of ILM flap under PFCL, and then application of cohesive viscoelastic under PFCL to keep the flap in place. After the flap is flattened and over the macular hole, we remove the PFCL, and as you can see, after the PFCL removal, the OVD and the flap stays in place, and actually this is the end of the surgery. So you can see the flap is in place, there is no endotamponade, you remove trocars, and this is it. We operated on 66 patients using this technique. The mean pre-op best-corrected visual acuity was 20/142. Most of the patients were phakic, and also most of the holes were large, whereas some of them, 9 holes, were very large according to the classification, over 650 micrometers. Macular hole closure was achieved in 98% of patients without using gas tamponade. With a single procedure, the success rate was 85%. In 8 patients out of 62, however, required the second procedure. Here, below in the table, you can see the change in best corrected visual acuity over the period of 6 months. Here you can see an example of a patient with large macular hole of 471 micrometers with best corrected visual acuity of 0.06. This is a pre-op image, and this is the image on the first post-op day. As you can see, the OCT is pretty clear. There is no gas, so it's easy to make. And you can see that the edges of the hole are already very close together, and there is a small bridge. This is at 7 days, and this is at 1 month. There is some residual gap in the outer layers of the retina, and this is the the status after 3 months, whereas visual acuity dropped because of cataract formation in this patient. And here's another example of a patient with a very large macular hole with visual acuity of 0.08. The hole diameter was 657 micrometers. This is a pre-op image, and this is the image on the first post-op day. As you can see the flap, however, there is no macular hole closure present. This is at 7 days. There is already some bridging effect. This is at 1 month, and this is at 3 months. There is some residual gap in the outer layers of the retina, and this is the patient at 6 months with the visual acuity of 0.3 and achieved 0.8 at 12 months after phacoemulsification. There were also some complications we encountered. In 4 patients, there was ILM elevation, the flap elevated, and we knew it probably does not lead to any closure. For that, we did a next day surgery that based on the fluid-air exchange, and we left the patient on the air and these eyes closed. In another group of patients, 4 patients, we observed inflammation in the anterior chamber with hypopyon. We were not sure if it was a sterile response to OVD. We immediately injected intravitreal antibiotics and also did intensive topical steroid treatment, and the situation resolved. And in 1 patient, we encountered retinal detachment, so we did the regular vitrectomy and gas, and in this patient, we also achieved macular hole closure. Conclude, as you can see, macular holes can be easily closed without filling the vitreous cavity with gas or any other tamponade. There are certain advantages for patients. There is no need for positioning, early air travel is achievable, and patients can perceive some visual acuity improvement already on the first postoperative day. There are also advantages for us, for eye doctors. We can do immediate OCT examinations. Ophthalmologists can perform fundus exams as well, so it's of advantage. However, it's a need for more studies to evaluate the risk profile of this kind of surgery. Thank you very much. If there are any questions related to this new technique, I'm happy to answer them in the discussion later in the session. Thank you.
Thank you very much, Martin. It's really very impressive presentation, impressive results, something new, and I think we have a lot of questions, but can ask you only a few of them. First, how long do you perform your surgery normally? This new method, so how long do you do flap, decaline, inject, visco, etc.?
Hello, everyone. It's good to see my Ukrainian colleagues, and thank you for the question. So, actually, it does not take much longer. Of course, you are using a little bit more different instruments. So you could see I use extra decaline that I don't use, we don't use routinely in macular hole surgery. I also like finesse loop instruments to flatten the ILM under PFCL, and you also use your viscoelastic OVD. I tend to use cohesive for this very situation because it tends to stay on top of the retina and keeps the flap attached. Certainly, there are a few more steps, so it takes a little bit longer than regular surgery. There is a learning curve to that. However, after all you've done, I think you have the benefit your patient can see on the first post-op day, and you can also do nice OCTs. And of course, in case a patient wants to travel somewhere by air, it's possible. And the whole situation also raises a question how macular holes close, because as you can see, you don't need any gas, any tamponade for macular hole to close. So this is a very interesting topic. I cannot answer you how the macular hole close. No one knows that. However, as you can see, gas is not necessary for that.
Thank you. I think you closed macular hole. It's very important that a flap is fixed to the retina. If flap doesn't fix to the retina, macular hole is not closed. I think that the main goal of our surgery, gas or flap, it doesn't matter, is to cover the hole. For large hole, I think we will covering it for longer time than for smaller hole. So we use for large hole long-lasting gas. I have about 100% of closure with very nice profile of the retina. Congrats you with a really very nice, very interesting surgery. I think some questions from Igor Novitsky. Professor Novitsky, please.
Thank you for your presentation. It was very interesting. Two questions. First one, what is advantages of using decaline?
Yes, so the advantage of that is it's easier to flatten the flap, ILM flap, and put it in place when you under decaline, and it's also much easier to put viscoelastic under the decaline on top of the retina. So it sticks and forms a very nice dome-shaped bubble that keeps ILM attached. For that, I use decaline. However, if you would like to try this technique without decaline, put OVD over ILM without decaline, it also works. However, in my experience, it's less controllable. So I suggest if you start this technique, try to use it try to perform the surgery under decaline, under PFCL.
Thank you. I see. In my opinion, it is sometimes difficult to pick up internal limiting membrane under decaline. It is necessary to pick up one time, one more time, and one more time. So it is a little bit difficult. Okay, and another question. In the cases of unsuccessful surgery, you performed second surgery. What was difference in technique in these cases?
So basically, what I encountered is that in two cases, flap elevated. So what I did a very simple fluid air exchange to make sure, so like a basic regular standard technique, to make sure that that the flap is in place under gas. In theory, I could actually repeat the whole process. So I could put PFCL on top of the flap, put the flap in place, and use OVD again. However, I decided just to go with a standard procedure, just because it was a pilot study. We were with the first to try this technique. We invented it. And for that, I decided to go with standard way. However, it's up to you. As you could see, I did not achieve, with the one surgery, I did not achieve 95 or 100% closure rate. With one surgery, it was 85%, so it's lower. I have to emphasize it, stress out. It's lower with the regular standard techniques. Is it a learning curve? I think it is. Is it the fact that patients sometimes, perhaps since they can see, they right away start their daily routine and perhaps they move their head and eye too much, this elevates the flap? It's also possible. I think more studies are necessary, and I urge you, if you want to try out this technique, please feel free to test it on your, to see on your patients how macular holes close. It's very nice to observe it in the first week, how actually the edges attach and the hole is about to close.
Thank you very much. Thank you very much, Martin. And congratulations with brilliant results. So need to go to the next presentation. Okay. The topic will be again about macular hole. Clear air macular repair. Зубченка Ганна. Від команди Андрія Дєдова, я так розумію, да? Прошу, будь ласка.
Good afternoon, colleagues. I'm honored to be here to share with you our latest findings in the field of the vitreoretinal surgery. Let's dive right in. For national disclosure, no. The treatment of macular holes remains a complex challenge in modern ophthalmology. The commonly accepted approach involves three-part closed posterior vitrectomy, followed by internal limiting membrane peeling and tamponade of the vitreous cavity with a gas mixture. However, the necessity of long-term tamponade remains a subject of constant debate, as it can negatively affect the patient's quality of life in the post-operative period. Is it possible to achieve effective macular hole closure using short-term tamponade? We believe it is, and that this approach deserves further investigation. Research objective: to evaluate the efficacy of short-term air tamponade in achieving closure of full-thickness macular hole. Sources: as you can see, this topic has already sparked plenty of interest. We're just here to keep the conversation going. Retrospective analysis was performed on 50 operated eyes with full-thickness macular holes ranging in minimum diameter from 77 to 900 micrometers. All patients underwent 23-gauge 3-port pars plana vitrectomy, ILM peeling, and endotamponade using sterile air. In phakic eyes, simultaneous phaca emulsification with intraocular lens implantation was performed. Face-down positioning was mandatory for the duration of the tamponade. During the first post-operative follow-up, the volume of sterile air in the vitreous cavity accounted for approximately 2/3 of its total volume. Preoperative and post-operative assessments included retinal evaluation using optical coherence tomography included. On December 10, 2024, Russian missile strike destroyed to the basement our medical facility, resulting in the complete loss of diagnostic equipment, including OCT device. Along with the equipment, digital archive containing patient diagnostic data obtained via OCT was completely lost. Due to the unavailability of original digital data, an alternative evaluation method was applied. This involved retrospective analysis of surgical video recordings. Measurements were carried out by comparing visually identifiable hole diameter with the non-diameter of the vitrectomy probe used during surgery. Therefore, some of the hole diameter values presented in the bar graph should be considered approximate. In the following bar graph, we present the correlation between post-operative visual acuity and the diameter of the macular hole. Let's take a closer look at these results. Blue bars represent primary closure, whereas the orange bars indicate cases where closure wasn't achieved. Among the 50 eyes operated on, primary closure of the macular hole was achieved in 38 cases, 76%, indicating the efficacy of the proposed treatment approach. In 12 cases, secondary surgical intervention was required to achieve complete closure. Notably, no significant complications were observed in these patients, and stable closure was eventually attained. Let's take a closer look at the cases where primary closure wasn't achieved. Among the 12 eyes without primary closure, 9 had a minimum hole diameter greater than 500 micrometers, accounting for 75% of the failed cases. In the remaining 3 cases, the minimum hole diameter was under 500 micrometers. So, the next bar graph focuses on cases with macular hole diameter smaller than 500 micrometers. Let's review the results to better understand how hole size influences the effectiveness of our treatment approach. Based on our previous analysis, we can conclude that larger hole size may limit the effectiveness of sterile air as a tamponade agent. Therefore, sterile air may be a viable option primarily for holes less than 500 micrometer in diameter. Overall, the success rate of primary closure using sterile air was 91%. Obtained results confirm the feasibility of using sterile air as a tamponade agent for patients with minimum diameter of full thickness macular hole up to 500 micrometers. Considering the high effectiveness of this method in cases of small hole size, it can be regarded as an alternative to traditional tamponade agents. The method had shown positive results in both cases in a short-term and long-term perspectives. Patients who received sterile air had a shorter rehabilitation period compared to those who treated with other methods. Advantages of the method: reduced cost of surgical treatment. Sterile air is significantly less expensive than gas mixtures, reducing the financial burden on healthcare facilities. Shorter duration of impaired vision. Faster absorption of air tamponade results in less visual discomfort postoperatively, enhancing the patient's quality of life. Lower risk of transient postoperative ocular hypertension. Unlike expansive gas mixture, sterile air doesn't exert significant pressure on intraocular structures, thereby reduce the risk of transient IOP elevation. Limitations of the method. Short-term tamponade cannot reliably close holes larger than 500 micrometers. As the study results show, for macular hole exceeding this size, the efficacy of sterile air decreases. In such cases, long-lasting gas tamponade may be required. Take-home message: long gas, long hand motion, clear air, 91 success rate. Thank you for your attention.
Brilliant presentations. Thank you very much. Very professional style. Our congratulations. Some questions from the panel. Professor Sergeyenko.
Thank you. And how you find clear air in Zaporizhzhia, because all air in Zaporizhzhia was spoiled by Russian rockets?
We have some funds for our patients.
And in cases of large macular holes, do you use clear ELM peeling or do you use inverted flap?
We use ILM peeling and we use long-lasting gas, so we don't use sterile air for diameter of macular hole more than 500 micrometers.
Thank you.
Thank you.
Ще питання, професор Новицький, будь ласка.
Another questions?
How long do you think effective air bubble exists in the eye? I mean effective air bubble which can tamponade macular hole.
Till that time, till gas bubble located on macula. So it's on 3 days. After that, it's not effective, and we have a bubble in the up of the vitreous cavity, and there is no sense of this bubble. Thank you.
Congratulations.
Thank you.
Thank you very much, Andrei Vladimirovich. Great. So we continue the topic about long-lasting gas and the benefits in macular hole surgery. And the next speaker, Rozanova Zoya Anatolievna, with a presentation about gas tamponade prolongation as treatment of unclosed macular holes. Please.
Thank you. I want to say that the more macular surgeons, the more opinions. And about the endotamponade by clear air, it is one article where they say that the patients must maintain the face-down position exactly after second or third day of the operation where the gas bubble is small. So, but it is not my topic. no for national disclosure. The idiopathic macular holes occurs 7 or 8 cases per 100,000 population annually. Females are females are ill by this disease 3 times often than the males, and about 11% of the patients has bilateral macular hole. The key mechanism of the macular hole formation are vitreofoveal traction, ILM thickening and formation of the tangential traction of, over the retina, and hydration of the and edema with formation of the cysts intraretinal, which may which play a role in the enlargement of the macular hole without any traction from the ILM or posterior hyaloid. The gold standard of idiopathic macular hole treatment is vitrectomy with thoughtful relief of the, which relieves the vitreofoveal traction, ILM peeling, which remove tangential tractions, increase the retinal elasticity, remove the potential scaffold of the epiretinal membrane formation, and macular hole reopening. Gas tamponade, which approximate the ages of the macular hole and avoid migration of the intraretinal intravitreous fluid through the hole in subretinal space, and maintaining the tilted head tilted posture. There is no consensus, as we can see here, about size of the ILM peeling, about duration and which gas to use for macular hole treatment, and how long the patients may have to contain face down posture. As if we see that the macular hole can close the next day after the surgery. So to avoid side effects of and trauma, to minimize trauma and side effects of ILM peeling, gas tamponade, and for patients' compliance to the face down positioning. The most of the surgeons try to make the ILM peeling size not big, to use short acting gases or air, and not to shorten the period of the face down position of the patient. And it works. So the efficacy fluctuated from 74 to 95% in all the literature we analyzed. But what to do with the patients where the macular hole did not close? So we, as usual, so as we see that the majority of the surgeons take the crucial role in the macular hole surgery to the ILM peeling, the reoperating with the extent of the ILM peeling, size of the ILM peeling, or use inverted flap or platelet-rich plasma. So everything that previous lectures told. But we decided that the gas tamponade play not so is also important in the macular hole closure, and so decided to prolong gas tamponade in the patients with the macular hole which not closed, and where we knew that the ILM peeling has a size not less than 2 diameters of optic disc. So it was adequate to the macular hole size. And to avoid a rare operation, we performed the substitutive 15% C3F8 tamponade. At the period of the 6 years, we have 7 patients with 8 eye. Their initial macular hole duration was median 2 months. Initial median visual acuity 0.1, and apical macular hole diameter was 375, and basal 820. And after vitrectomy, 25 gauge with posterior hyaloid removal, ILM dyeing by the brilliant blue dual, and ILM peeling about size, about 2 diameter of optic disc in 6 eyes, and forward sparing technique, our modified forward sparing technique on 2 eyes, and 20% so short active gas was used on the 7 eyes, and fade down posture they maintain only 1 week. And at the control visit, which was from 10 days to 1 month, despite that the macular hole did not close, the visual acuity increased statistically significant, and also the sizes, apical and basal sizes of the macular hole also became smaller. And we, in two cases, we went to the reoperation. It was the patients who did not operate it for the first time in our clinic. And after dying of ILM, we discovered that the macular that the ILM peeling size is about 2 diameters of optic disc, and we did nothing but the fluid gas exchange, and that's all. On the other eyes, we performed the substitutive gas tamponade. Here in the pictures you can see this method. At the inferior part of the eye, through the pars plana auxiliary body by needle 27 gauge, which is connected to the syringe with the air gas mixture. Step by step, we aspirate a little amount of the vitreous fluid and inject a little amount of the gas till we fulfill all the vitreous cavity by the gas, and the intraocular pressure is normal. And asked the patients to maintain the face down positioning for 2 weeks longer. And on the control next visit, all the macular holes closed in our group, and visual acuity improved, not only comparable to the initial, but comparable to the second their visit. It's one clinical example. Female, 62 years old. The initial macular hole diameter is 580, and visual acuity 0.17. When on the second visit, where the macular hole did not close, it became a little bit smaller, and we performed the fluid gas exchange through the syringe. And on the 4th day after it, through the gas, we made a CT and saw that the macular hole is closed. We thought that it's so, and after months after the gas resorption, the visual acuity macular hole is closed and its profile is correct, and the visual acuity is 0.5. The next clinical example is interest in that after the operation, when the patient visit us to the control visit, and we saw her not closed macular hole, its basal diameter became larger than before the surgery. So the edges of the macular hole rises after the our operation. But we also have performed the gas tamponade and prolonged the face down position, and also the macular hole closed and with correct profile of the closure, and visual acuity raised from 0.08 to 0.3. So the conclusion is that in cases when the macular hole don't close after one primary surgery, you may try to prolong the gas tamponade by 15% C3F8 if you know that the ILM peeling diameter is about 2 diameters of optic disc, and the initial macular hole size is equal or little bit less than 400 microns. And that's all.
Thank you very
for
much.
attention.
Thank you for to present our results. It's really very interesting things that simple gas can solve a lot of equations, and they really can't understand a lot of things. For example, some surgeons think that additional agents then they put into the hole, I don't know, amniotic membrane, another substitutes, maybe retinal graft or something else can help us. Simple gas can help in a lot of number of cases. Only prolong the gas tamponade and we solve a lot of equations. So our conclusion is for naive patient, small hole, small gas,
Yes.
big hole, big gas. So thank you very much.
Yes,
Doamna Dolina,
and
for
I
interesting
want to
presentation.
say that here our very many opinions about macular hole surgery, agents, and so on. It is the example that we really don't know how the macular hole closes and what we must to do.
Small questions from Professor Sergeyenko.
Yes.
I think that fresh air and inverted flap can be also nice. And for Zoya, what is the rate of cataract and cataract surgery in 1 year after operation with long-term gas?
Yes, it is a disadvantage. Certainly, the case of cataract, in this series I don't count it because, but during the year, as usual, or 2 years, the cataract became that we must do phacoemulsification.
Thank you very much. So the next speaker, Chumakov Evgeny, with our results. Also nice presentation about treatment of SELED for the macular retinoschisis, our experience. Also very rare.
Thank you everyone for coming for this conference and those who are watching online, I hope. Yes, I want to like demonstrative presentation about our experience in Filatov Institute regarding treatment of stellate non-hereditary idiopathic foveal macular retinoschisis. First of all, I don't have any financial disclosures and the authors of this presentation as well. If you're speaking about stellate hereditary idiopathic foveal macular retinoschisis, it's a unique entity that was not so far long ago described in the literature and the world as well, and it's also regarded as a rare entity. As you can see, only 2% of all retinoschisis cases are attributed to this pathology. Maybe it is related to the fact that this type of schisis has been recently described and the diagnosis is not that high, depending on the criteria, but mostly it's a diagnosis of exclusion. We need to exclude other possible causes of retinoschisis, including hereditary causes, for example, X-linked retinoschisis or enhanced C-cone syndrome, also inflammatory causes, and so on. In our experience, although it's mostly unilateral and affects females more often, males can be also affected and bilateral cases are also described. Ophthalmoscopically, it has a very characteristic spoke wheel pattern, which is also characteristic for other foveal macular retinoschisis, but in this case, the membrane, internal limiting membrane, has a glass appearance, as you can see on this photo of our patient. It is postulated that possibly this pathology is associated with vitreoretinal traction and other biomechanical forces that are pulling the retina. So the schisis develops, as well as the macula can be infected and also the peripheral area. I want to present one of our clinical cases. This is a male patient, 54 years old, that was complaining of progressive bilateral vision loss. As you can see, best corrected visual acuity on the right eye was 0.3, and best corrected visual acuity for the left eye was 0.08. You can see both two images, fundus images of the left on the right eye, and the left eye also had a significant epiretinal membrane near the optic disc head. Importantly, the patient didn't have any genetic history because we need to consider hereditary causes as well. This is OCT of both eyes of this patient. The upper one is the left eye and the lower one is the right eye. As I already said, the left eye had the significant epiretinal membrane. And also you can see these characteristics spoke-like appearance on end-phase images that I was talking about. Here is the video of this patient which was operated. We performed pars plana vitrectomy with internal limiting membrane peeling. You can actually see how the membrane is peeled, appearance of this membrane. This is actually why it is called, we call it glass appearance of the membrane, and these spokes you can see. Here the membrane is removed using ILM forceps, in a single piece, as you can see. The operation was concluded with air tamponade, just in advance. The remnants of the membrane are also removed with vitrector probe, and the tamponade is the finishing tamponade. At 3 and 6 months post-operatively, vision acuity improved from 0.08 to 0.3 in the left eye, and we are planning to operate the second eye because this condition is bilateral. The first image of the presentation was another eye of this patient. This is OCT images of the left eye. As you can see, the schisis in the area where the epiretinal membrane was present completely disappeared, although It also did not disappear in the area around the macula, yet it became smaller, approximately 200 microns smaller in this case. In our experience, this is actually also our patient with bilateral stellate retinoschisis. As we can see, some patients, and most of them are asymptomatic, and asymptomatic patients can be just monitored for vision loss when it occurs. As an indication for surgery, we consider vision loss that is significant and development of subretinal fluid. In our cases, we also perform internal limiting membrane peeling, and we saw in our patients that the area of schisis decreased, the thickness of schisis decreased, or it completely disappeared only in the area where the ELM was peeled and not outside this area. Comparing to international experience, the literature and other colleagues state that yes, this condition is usually stable, but it can lead to progressive vision loss. They also say that it may resolve spontaneously, supporting the suggestion that vitreoretinal traction play a role, especially when posterior vitreous detachment occurs. Some patients may develop spontaneous resolution. Indications for surgery include also vision loss and development of subretinal fluid. Some colleagues manage it without LM peeling with vitrectomy, some manage it with LM peeling, it's also, there's one report of effective dorsal limit treatment and 2 reports of ineffective dorsal limit treatment when they try to manage patients conservatively. As a conclusion, we can say that this pathology is really rare, and it becomes increasingly diagnosed in the world, and we have some experience. Indeed, tractional biomechanical forces play a role considering the results of our surgery. Patients are usually monitored for vision progression, and when vision loss and subretinal fluid develop, then we recommend surgery for such patients. And we still think that ELM peeling is advantageous in such patients. Thank you for attention.
Thank you very much, Evgeny. We have a few questions from the panel. Please, Professor Sergeyenko.
What is the goal of, what is the reason of gas tamponade after removal ALM? Air, yes.
In our institution, we simply don't prefer using BSS as a tamponade, so usually we just perform air tamponade for such patients. There's no reason for tamponading or for example, in macular holes.
And do you do a core vitrectomy, not complete vitrectomy?
It's without shaving of the periphery, mostly core vitrectomy, yes.
Thank you.
Any questions? Thank you very much, Evgeny, for nice presentation and nice style. So the next speaker, Professor Andrei Sergeyenko, surgical treatment for X-linked retinoschisis. Continue topic with schisis.
Long-term results of X-linked retinoschisis. Dear colleagues, genetically determined a lack of protein retinoschisin can lead to complete deterioration in interaction of retinal layers and can lead to decrease of vision. The idea of this study was to activate remodeling of the retina due to microtrauma of Macular cells. ELM removal is a proven tool in the management of complicated macular edema, but in retinoschisis, mechanism of regeneration may differ. The aim of this study was to investigate the long-term results of ELM removal in young patients with X-linked retinoschisis. We're afraid of progression of atrophic changes and of our patient and are not eager to expand our group. The group is 3 patients for eye with the age from 6 to 16 years, which underwent with X-linked retinoschisis, who underwent ELM removal and so after staining of brilliant peel. We did not use any tamponade during the surgery. For better visualization of our results, let me introduce you the one clinical case with a long-term observation, 19 years. 2005, the boy, 16 years, are complaining of decreasing of vision of the right eye, complicated retinal detachment with retinoschisis. Several operations were performed, but visual acuity was low. Year 2006, visual acuity decreased on the left eye, and it was the premiere of retinoschisis. We performed ELM, we performed surgery with ELM peeling, and you see the OCT dynamic and visual acuity dynamic year by year. After ELM removal, thickness of the retina gradually decreased and visual acuity gradually increased from 0.4 pre-op to 0.6 1 year after operation and 0.8 2 years after operations. 11 years after operations, the retina is stable, no cystoid changes, visual acuity remains 0.8. The left, the right eye is hand movement, and we could not see any layers in macula. Retina is completely flat, we could not differentiate the layers. The 19 years after operations, visual acuity decreased a little bit, but patient did not notice that, and he is completely socially adopted. And I couldn't understand how can see so well in such macula. I have to notice that all patients have improvement of visual acuity after operation in long term, from 6 to 19 years. And in conclusion, removal of ELM for X-linked retinoschisis can improve and preserve visual acuity in a long term. After removal of ELM, the retina transformed with a decrease of thickness and the differentiation of layers, but without a sign of atrophy. Thank you.
Thank you very much, Andrei Nikolaevich. Very interesting topic and very interesting technique. So maybe some questions, Zoya Anatolievna.
Do you use any metabolic drugs to maintain their visual acuity?
No.
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 Nothing.
Because only vitamins, because this is child.
Okay, thank you.
Completely agree with your technique, and we also feel like in previous presentation, Evgeny Chumakov asked about that it works only in the area of the peeling.
Yeah.
So it's like stimulation of the glial cells of the retina, and it works perfect in this area. So congratulations with the nice results. Thank you very much. So need to continue. And the next speaker, Nicholas Labauri, with presentation about macular buckle for a myopic tractional maculopathy. Please, Nicholas Labauri. Oh, nice to see you again.
Nice to see you again. Such a great pleasure to see you, Dr. Umanis, Dr. Sergeyenko, Dr. Novitsky. So congratulations with a very successful meeting you are having here. Is my slides coming on the screen? Yes. So I'll be talking about the recent technique we just invented of macular buckling, which is used for tractional maculopathies in high myopic cases. And as we all know, so in those cases, so we are having the anteroposterior traction as well as tangential traction. Although the traditional method to manage these cases is a vitrectomy and ILM peeling or without ILM peeling, we still need some the macular buckle to shorten the anteroposterior axial length. And we have different clinical scenarios like the vitreoschisis, retinoschisis, the lamellar holes, or the full thickness holes, or combination of those, or sometimes we have those clinical manifestations as a solitary entities. So just to go quickly through these cases, here we see the posterior vitreoschisis. Here is the retinoschisis. The slide shows the retinoschisis with the posterior detachment without a macular hole, and here we see the detachment with full thickness macular hole. And as I already mentioned, the traditional approach is a vitrectomy, ILM peel with a staining. Sometimes we peel across the macula, or sometimes we just use the fovea sparing ILM peel in cases when we don't have the macular hole, or sometimes we use the inverted flap technique. However, there is still some scenarios when we feel that we don't have enough tissue to reattach the detached retina or to close the macular hole. And sometimes when we do just a vitrectomy, the macular hole either creates, or when it exists, sometimes it gets enlarged. We know that we have different shapes and many different types of posterior staphylomas, but mostly the most common types we see in our clinical practice are depicted here. So it can be just a barrel shape, no staphyloma, but a barrel shape, elongated eye, or we may have narrow or wide central staphylomas, or the staphyloma can be shifted towards the nasal part or towards the optic disc. Optic nerve head. So this is the schematic the schematic staging introduced and suggested by Dr. Parolini. It's a very great help and great guide to diagnose properly those conditions and treat them appropriately. Here we see different kinds of macular buckles, different kinds of implants, and mostly I divide them with a single arm at the 1-point fixation and the 2-point fixation arms. We do have a few implants which needs a 3-point fixations that we fixate in 3 different places onto the sclera, and the head goes under the fovea to indent the fovea from outside and shorten the actual length. Here is the schematic drawing of the macular plomb which we introduced. And so actually this is the material, the solid silicone, which is used just for the regular bucklings. It's a 240 band, silicone band, and the round element, which is indenting part and can be actually made by hand just before the implantation by the surgeon. We already have these implants in our armamentarium, in our operating theaters. And on the video, I will show you how it is made. It just takes about 10 minutes. So this procedure can be done absolutely completely without any suturings, because we use a belt loop tunnels to fixate this implant in 2 different points, which is the inferonasal and supraronasal parts. So let's go through the cases. The case so far, I have done 9 cases, so it's just almost yes, this is just 1 year as we are doing this technique, and we have collected only 9 cases so far. And this is a case of high myopia, and you see there is a posterior detachment with the schisis. There is some retinal membrane you see here, and there is still vitreous attached onto the fovea. Here it has to be the video. This patient, okay, so the B scan shows the central staphyloma with a retinal detachment here, which is a small size staphyloma. This patient has had radial keratotomies many years ago and still phakic. So we are trying to preserve her lens crystalline. And you see I'm using the trephine, the corneal trephine 7 millimeters to harvest this round shape, the silicon indenting part from 2 to 7, 8 silicon tire. And I'm doing the grooves in each side using the crescent knife and passing through these grooves, this 240 bend. It just showed that I have isolated the inferior oblique muscle, which is very important. Otherwise, this we will not be able to reach the foveal zone. So this the bend goes under all the muscles except the medial rectus, because we need to bring the ends onto the infranasal and supranasal parts. So this is a part of the vitrectomy. Nothing is interesting here. So I'm usually I just want to show that for the ILM peel, I always use the flat lenses to just to exactly see what tissue I'm grasping, because the grasping is very important. If we damage the retina, we may create some extra holes, and our elongated outcomes will be much worse. And the same quadrants, which is the infranasal and supranasal, I'm doing this belt loop scleral tunnels and passing these bands and fixating these bands with the Vasquez sleeves on each side. And you see I'm trimming here the ends, and this is pretty much the procedure. So we need here the 360 conjunctival opening, and you see here the before and after, how it looks, the OCT. The retina is attached, and this is on MRI, and MRI shows the central indentation by the indenting head here of the macular zone. So sometimes when we have some fluid, residual fluid, we need to give it time until it reabsorbs completely. Actually, this was a case where we can just use a macular buccal first, just as a standalone approach, and if necessary later on, if fluid doesn't reabsorb, then we may go and do the vitrectomy. However, here I have done the combined case. So this is the autofluorescence on the right side, which is very important just to observe in the long run what's happening with our RPE, because I have a few patients with different kind of bucklings after 7 years. One case I just remember I recently saw, after 7 years, this patient had the 0.7 vision, and just the vision was worsened. Suddenly, a patient came, and I have every 6 months observation. And at 7 years of follow-up, the RP was surprisingly damaged, and the central vision was gone. So that's why those patients I'm observing very closely, and then I'm observing every six months, and autofluorescence is one of the must diagnostic methods which I'm doing for them. So here there are quite of many advantages. I will tell this and speak about this later on. This is another case with a retinal detachment. You see the central part of the retinal detachment before and after surgery, and you see the retina is attached. And here is a before and after. This is how it looks on the autofluorescence before and after. And this is how it looks, just another case, the retinal detachment and posterior staphylomas, the central staphylomas, large size, before and after the indentation on the B scan. This is the third case with a retinal detachment associated with the macular hole, the central macular hole, before surgery, and on the right side 2 months after the surgery with a macular hole, as you see here, which was closed. And you can notice that the indenting part of this buccal is not convex, it is concave. So that's why, so we are not getting the dome shape indentation. Instead of that, so to compare to other buckling elements which is available so far, which has a dome shape indenting part, and this dome shape indenting part actually causes the clinically significant metamorphopsia. Sometimes with these implants we are getting quite a high visual acuities, but still patients are not happy because of the distorted vision. And whoever has experience with the macular buckles, probably everybody would note that this is the main issue why patients are not very happy. So this is the autofluorescence before and after, as we see in another case, and how it looks on the B scans. It is a double shadowing. One belongs to the optic nerve, and another shadowing is caused by the indenting part itself. So there are many advantages if we go through in details. Many advantages of this kind of implant to compare to the traditional, let's say, already available implants. So the first thing is that it is not custom made, so you don't need to order it and wait it, so to send all the measurements, because for example, some companies are doing custom made buckles, the elements, and it takes time. For example, it happened in my life that I had a patient with a limited posterior detachment as a macular hole, worse visual acuity, but not the total detachment. And until I ordered the buckling element and it arrived to Georgia, which took about 3 weeks, the patient came with a total retinal detachment and just a hand motion of vision. So it's very, it's a big advantage when you have this buckling element in your operating theater, and it's a great thing that it has every surgeon in every country. So it's not dependent on the actual length. It can be used in any kind of actual length. So it is the main advantage, as I already mentioned, is that it indents. It doesn't indent. And doesn't causes a dome shape indentation. It causes a flat shape indentation, and we are getting less and less metamorphopsia. I don't really have patients so far who is suffering, how to say, and it's intolerant to the metamorphopsia, whatever they have. So it's very important to notice that in most of the cases we can use just a buckle if there is no full thickness hole. Let's imagine there is a retinal detachment with a schisis, or just a schisis, just a buckle. And sometimes if you have the subretinal fluid, it takes time, sometimes several months, even up to 1 year, until it dries up completely. And patient's vision is improving gradually. And in these scenarios, we have to wait and watch. But if we have the full thickness macular hole in combination with a detachment, and we feel that the only vitrectomy with the island peel to relax the retina and reattach the retina and at the same time close the hole is not enough, then we have to think about additional or supplementary macular buckling as well. So we don't need here the sutures, but it's not a great advantage, because when we do the major surgery, so it's not a big difference whether you use the sutures or not, but still, just to mention. And also it's affordable, it's cost effective, because it costs just nothing to compare to other kind of bucklings available so far. The disadvantages are that we need to open the 360-degree conjunctiva, we need to tug all the muscles, and also surgeon has to have some experience how to find the inferior oblique, isolate inferior oblique muscle, and care has to take it to not to miss it, or not to pass the band in between the muscle. You have to isolate completely, and in a proper way you have to pass it underneath. It's very important. It's the most difficult part of the surgery. These disadvantages I already discussed about this, and this was pretty much I wanted to say. So this so the preliminary results which we are having, it's and if you are interested in more details, it will come soon on the Retina Today journal. It's ahead of print now. It's not already issued, but will come soon. And that's all. Thank you so much for your attention, and I would love to get the questions if it will be any from the audience.
Nicholas, thank you very much for brilliant presentation, and as usual, amazing surgery. We're waiting for you every time something like today, amazing surgery, and you did it. So we're amazed, really. But as for me, I can find indication for buckling in my experience for my patients. I perform vitrectomy with peeling, and hopefully everything is more or less fine in 90-95% of my surgeries. So what is your recommendation, strong recommendation for buckling in your experience? First question.
Okay, so I have seen couple of cases. Let's say the couple of cases where the retinal detachment with a high myopia, posterior staphyloma, which I have shown, which is a small staphyloma with just a huge how to say excavation, which will not allow you to reattach the retina. And sometimes the attempt was made to just do the vitrectomy and ILM peel, and sometimes there was no hole, and after the surgery we were getting the holes. I have seen many patients referred to me with a macular hole, which was not there before, was operated for the myopic detachments, and patient had bad vision, and it became even worse. So in some cases, usually it's, for example, now let's imagine you have the high myopia and already our nasosensory retina is compromised, and you are doing just a standalone buckle. I have some cases I didn't put here, but I have some cases just a standalone buckle, not touching anything inside. And you are reattaching the retina, and patient is happy, and you are achieving, and your visual acuity will be definitely much better than you may achieve with a vitrectomy and ILM peel. This is another, so that's why Dr. Barolini has very good schematic drawings of the stages of the macular holes and appropriate treatments where the vitrectomy is indicated, where the combination is indicated, or the standalone buckle. But still, everybody has to go in his or her own way. I think after the big experience with the macular buckles, and still, I don't really in my hands. Not all the holes can be closed with just a vitrectomy and the ILM peel, or not all the retinal detachments with the schisis can go away just with the internal approach. That's why it made me just to think about this. It's already more than more than 15 years I'm doing this, starting from the endoplombs, which is not available now for many years, going through many different implants, just to observe how it behaves in the eye and what is the long-term results. And I already talked about the RPE atrophy, which is one of the, which may be, and I think the main reason is the dome-shaped indentation at the central part, which harms the RPE and the choroid as well. And also the main disadvantage of the macular buckle is that the patients are getting the metamorphopsia. That's why it never became a popular around the world. And the third thing is a learning curve, because actually it is a big pain for the surgeon to do the macular buckle, especially when you are starting this technique, because you need to isolate the muscles, you need to find the many things, you need to hit the foveal zone to indent. So I think those are the reasons why macular buckle is not so far and will never be the standard and very popular approach worldwide. But for me, still it is necessary, unless even many surgeons, they think that a regular buckle for regular detachments is not anymore necessary. But I still think maybe I'm a very old school, the old school of thought. But I think that the regular buckles also is necessary, and we should not lose this tradition to train our fellows with this, because I think that sometimes you need the encircling buckle to get better results in the retinal detachment cases, and same happens with high myopia.
Thank you, Nicholas. Looking forward for our meeting the next year. Thank you very much for a very interesting topic and interesting presentation.
Thank you so much.
Goodbye.
I hope I'll come in person, and I will attend your conference one day.
Thank you.
Thank you.
Bye. And the next speaker, Barbara Parolini, with myopic tractional maculopathy and her experience in this topic. So, welcome, Barbara. А, нема Барбари? Ну, давайте, може, ну, там у нас... Вона була взагалі на початку? So, unfortunately, we don't have connection with Barbara still, so we need to finish our interesting session and invite our next moderators. Thank you very much. Thank you for all. Thank you for our guests. Thank you very much.
Окей. Але я також можу. Дякую.